I'm excited about this. This is our first presentation. We created this facility with the idea that we would have a room where we could do this, and as well as do yoga and Tai Chi and things like that. So this was our test run. We crammed about 40 people in here pretty well with tables. So we certainly intend to do more of this in the future. Dr. Huckabee's a tough act to follow. I'm going to do my best. I'm going to present a slightly different perspective on this, and it all fits together, believe me. So I'm going to start just with giving you a little evolution of my journey in addictions, and as well as the path that a brain-based approach has taken, particularly the neurofeedback to treat addictions. So I started out after getting my master's degree in rural North Florida as an alcoholism program coordinator. In reality, I was the alcoholism program. It was a one-man show. Prior to my arrival, the judge was sentencing alcoholics to hand abuse as an alternative to jail. And that was pretty much it. They had a little mental health center there, but no addiction program. So I did everything. So I'm kind of telling you this to let you know that I earned my stripes. I was making house calls. I was driving drunks to detox. I was going to these seedy hotels and seeing awful stuff, seeing people have seizures. And I thought, there's got to be a better way. There's got to be something better than this. And so then my next stop was going back to the University of Florida to pursue my PhD. And found myself, because of my experience, working in the alcohol abuse prevention program. And that worked out nice as I was able to do my dissertation and get paid to do my research. And that was an important thing to do as well, because we were dealing with freshmen and sophomores that were learning how to drink and how not to drink. And that was the basis of my research, trying to help them make the proper decisions. From there, I had a job waiting for me to be executive director of a treatment center called Bowling Green Inn, a new one that they were going to open in Louisiana, Dr. Huckabee's territory. So as part of my training, I worked as an online counselor in Bowling Green, Florida, which is in the middle of nowhere. It was difficult. I was living in Gainesville, had a wife and baby. I would drive down there Sunday night, spend the week there, drive back for the weekends. But it was great training, and so I was doing the online counselor work and learning how to do the administrative part. Went there to Louisiana. I was executive director of a 44-bed treatment facility. We built it from the ground up. It was at that point owned by a corporation. And we had a really good treatment program. My emphasis was always on quality of care. Corporate emphasis was always on bottom line. It got more and more uncomfortable. So I eventually made a move. And then came back to Florida and took a job as executive director of the Life program in Osprey. This was a private nonprofit substance abuse treatment program for adolescents. Another challenging position. But again, I'm working in administrative, but really missing the clinical part. So I went from there to a private for-profit program called Anabasis, where I was the clinical director and program director. And we were doing good stuff there, but it was still very frustrating. As you can imagine, I'm on a burnout path here, because my big frustration was I always felt I was working harder than the people I was trying to help. And again, I'm thinking there's got to be a better way, got to be a better way. And then I discovered the neurofeedback, which I'm going to talk a little bit about. And that was really the first time I really got excited about being able to make a really big impact in addictions. And eventually evolved out of that into private practice. And as Ryan discovered on my resume, I'm very ADD and I'm interested in everything. So I do a little bit of this, a little bit of that, and private practice suited me quite well. And I was drifting away from addictions, but something keeps pulling me back. And as you can see, we've kind of come full circle now. So what really changed my mind was running across some, changed my life really, running across research on the Peniston protocol, which came out in 1990. And this was based on an observation that when you look at brain waves, alcoholics have an excess of beta, which is a faster brain wave frequency, and they're really deficient in alpha, which is an important resting rhythm, idling rhythm in the brain. And they also had excess beta endorphin as a response to the stress they were creating in their lives. This protocol was developed at the Menninger Clinic in Topeka, Kansas, where they had done a lot of very interesting biofeedback work for years. The initial, actually Peniston went to Menninger, got the training, the alpha theta training, came up with this idea for applying it to the alcoholics he was treating at the VA hospital. So he went back and put together this study. And in his experimental group with these chronic alcoholics, 80% of them stayed sober after going through the treatment phase, which I thought was phenomenal because nobody was hitting percentages like that. Even though it was a small n, it was very encouraging. So what we kind of knew, noticed the data in this 1990, kind of knew that there was decreased serotonin found in antisocial, violent, impulsive alcoholics, associated also with depression, increased norepinephrine, generally over-aroused sleep disturbance, tolerance to dopamine, and eventually an inability to produce dopamine. And so drinking to feel good started to turn into drinking to avoid feeling bad. GABA adapts to the presence of alcohol, increased sensitivity to excitatory neurotransmitter glutamate, increased beta endorphin, and all that I try to translate into my language, which I was beginning to learn in terms of the EEG, how you interpret the EEG in the brain. So the first thing is decreased amplitude of alpha. So the alcoholism, and this applies to all drugs, but my introduction was in alcoholism, and I learned that there are a lot of different dynamics. Some are over-aroused, some are under-aroused. But in alcoholism, it's an over-arousal and inability to stay calm without drinking. So increased high beta, which is associated with excitability, decreased relative power alpha, that's relative to the beta, except when they drank, and then that artificially elevated the alpha, which was an interesting finding. And increased latency and decreased amplitude of the P300, that's an important metric in terms of information processing. So I went out to Menninger to learn about alpha theta, and the first thing they did is start talking about autonomic nervous system, the peripheral nervous system, and I wasn't really understanding what that was all about. But then the research was showing when they looked at the autonomic system, there was a resting baseline showing sympathetic nervous system activation, which is really the fight or flight or freeze response, people getting stuck in that. And then the alcohol had a strong effect on the SNS, and another reason why the alcohol was reinforcing for them. It would help them be able to modulate that sympathetic response. And then what they had been working on at Menninger was the autonomic nervous system was found to be trainable through biofeedback, relaxation training, and hypnosis. Some of the psychodynamic factors: learned maladaptive behavior, external locus of control, and that's an important concept. I think it's kind of a belief that something outside of myself can make me complete, can help me feel better. And that's, the mindset in America. You go to the doctor and you get a pill, and that's going to make you better. So my work for a long time had been trying to help people make that shift from external locus of control to internal, helping them see that they have within themselves what they need. And then all forms of addiction involve some sort of attachment, an unhealthy attachment to a substance or a behavior. So back to Peniston Kukulski, when I delved into their research, they had 10 chronic alcoholics in their experimental group, 10 chronic alcoholics in control group, 10 non-alcoholics in the control group. They measured EEG baselines, measured beta endorphin blood levels. They administered Beck Depression Scale, MMPI, MCMI, and 16-PF. So their protocol was started again with finger temperature training, which really didn't have, in my view, much to do with the brain. I learned otherwise. So that involves putting a thermistor on the finger and then applying kind of a passive volition to raise the finger temperature. What's really happening is you're quieting the sympathetic nervous system. You're allowing the blood to flow freely out to the fingertip. And that's a very difficult concept for many people because the tendency is to kind of bear down and try real hard, which gives you the opposite response. So it's about letting go and allowing, which obviously is important in addiction. Then they do a 15-minute baseline. And they were working, 01 refers to a point back here in the occipital cortex. They chose that point 1 because it's there's naturally more alpha in the back part of the head, but also they're in the visual cortex, and it's conducive to doing visualization work, which is part of this protocol. And on the left hemisphere, which is more the sensor and the analytical, so they wanted to quiet that. Oops. And then they did 15 alpha theta feedback sessions. And they were instructed to visualize rejecting alcohol, increasing alpha, and a personality change. So again, 80% of them stayed sober. This was a 13-month follow-up, whereas 20% of the controls stayed sober. They had significant increase in their alpha and theta levels, and a significant reduction in the beta endorphin, and improvement in the depression scale, improvement on the MCMI scales. I'm going to kind of rush through these. You can see for yourself there are some of the things they measured and some of the findings. Same with the 16-PF. So the surprising result, and this coincided with my experience as well, a lot of people that went through this protocol, if they relapsed, they didn't have a very good experience. Most of them over time lost their desire to use, and we didn't have very many relapses, but for many of them that did, they got very, very ill. They described it as a bone-aching, flu-like sickness after taking a drink. And it does suggest that there was some sort of psychophysiological reaction of rejecting the alcohol, which is what we had mentally rehearsed through our visualizations. So I kind of went over some of this. So the general biofeedback postulate and why it works. Any process that can be continuously monitored and fed back can be brought under a degree of conscious control Any internal process that can be triggered or controlled by suggestion, perception, stress, or other psychological process without volition can also be potentially brought under voluntary control. So that means we can take what we normally consider to be unconscious and involuntary and make it conscious and voluntary. So you can, on one level, you can literally learn to direct blood flow up to your fingertips. You can learn to decrease the sweating in your palms. You can regulate your heart rate. You can regulate your digestion. And you can change your brain waves. So in their work at Menninger, they found that body image changes associated with very low levels of muscle tension, general feeling of tranquility associated with hand warming, but you have to watch out for the drowsiness. And the alpha facilitates calmness and recall processes. Theta produces hypnagogic imagery. So the reason for feeding back and up-training both alpha and theta, we use the alpha for calmness, for like a focused attention, a meditative state, if you will, and ability to recall your experience. We encourage theta also to get them into this dreamlike reverie state. It's kind of the stage between wakefulness and sleep, and it's a fascinating state to be in. And the tricky part was getting a good balance of alpha and theta, and we would do that through manipulating some thresholds. Too much theta, they would say, I know I had some imagery or I was dreaming, but I lost it as soon as I came out of it. Too much, not enough theta, and they didn't have much of that kind of an experience. So again, from the greens at Menninger, 3 ingredients of self-regulation, self-awareness, and with biofeedback, you're facilitating that process by feeding information back. Passive volition, need to be able to let go and allow with intent established. And then visualization or perceptualization, make mental contact with the body and picture what you want to happen. And they did this with a variety of things to promote healing. So I took that and I developed my own protocol. Started with teaching people hand warming, and this was an important step to help them get to the point of surrender. And then we would pre-construct visualizations. The first one was a rejection scene. So I'd have them imagine being in a kind of a trigger situation where they could actually, feel the feeling state associated with that urge to use. My first volunteer subject from the treatment center was a cocaine addict, and when I asked him to start visualizing that scene, his nose started running, and he was saying, "Well, I'm there." So it was pretty powerful. So we would, in the visualization, we would have them put themselves in that scene, feel the urge to use, and then mentally rehearse a alternate behavior. So reject the usage and then do something more constructive. And we would pre-construct that verbally and flesh it out so that when we go into the process, you just play the movie. It's not a matter of trying to think about it. The next visualization was abstinence. Imagine your life being abstinent. And interestingly, a lot of them had more trouble with that than any of the others. And then the third was a sense of self. What kind of person do you want to be? What kind of personality changes do you want to make? So things that I learned from Menninger, to construct good visualizations, whether you're working on healing a part of your body or making some sort of behavioral change, must be relevant and meaningful to the trainee. So I would never create the visualization for them. I would have them create it. must be an image of desired change. If it's a healing thing, it should be somewhat anatomically correct and physiologically correct. Pat Norris did some interesting work with children who had brain cancer and inoperable tumors, and she used this alpha theta process and had them visualize the answer in their brain. One kid saw it as kind of an alien spaceship. Another one saw it as like a lump of hamburger, and then they would say, "What are you going to do about this?" So for the spaceship, he launched little fighter pilots that went in there and started attacking the tumor, and with the clump of meat, little Pac-Man that were going and eating away. And this is what the kids came up with, so it was meaningful for them, and it's something that they could engage in. It's always helpful to anchor it in all the senses. So when I have people visualize this scene, what does it sound like? What does it look like? What does it smell like? What does it feel like? And really anchor it that way. Pre-constructed and rehearsed, again, so you can just play the movie, and then you need to be able to hold it firmly in mind, while quieting your physiology. And then the other concept is you just plant the seed and let it go. So like a farmer doesn't go out and dig up his plant every day to see how it's doing. You plant it, you fertilize it, you trust that it's going to grow. So some of this doesn't make sense if you don't do neurofeedback, but we put the electrode back here at 0.1. We had reference to the ipsilateral ear around to the contralateral. We would do some baselines and set thresholds, and then feedback auditory tones. And I started doing this in 1990. I had a standalone machine, no computer interface, slide dials, and analog feedback, and it worked. We're much more sophisticated now, as I'm going to get to. And then I would do a verbal induction with them, so I'd kind of guide them into this state. And then I would cue them to do their visualizations and then let them go. With the goal being get through the visualizations, let them go, and then enter the witness state. So you just start paying attention to what's coming back. So we're trying to establish a dialogue with the subconscious mind, bridging the gap between the cortex and the limbic system that Dr. Huckabee was talking about. And then we would process the experience at the end. It's very fascinating work. Some of the common experiences, the hypnagogic imagery was very common, and we all experienced that. It's the dream state. Body distortions, that was always interesting. Sometimes they'd feel like they're getting really big or really small. Movement sensations. I would do this in a recliner chair, and the chair had a swivel, and people would accuse me of spinning the chair around or lifting the chair, that sort of thing. And none of that was happening. It was all just an altered perception. Frequently out-of-body experiences, which were always interesting. Emotional have reactions. This is something that you have to be careful about, because I think a lot of trauma is stored in that theta state. It keeps it out of access in our waking state, but if we get into this alpha theta state, sometimes that can come to the surface. And as a therapist, you got to be able to deal with that. And we don't go fishing for it, but it comes. And then a lot of aha experiences. Theta is a state of creativity and insight and understanding. A lot of times problems you've been struggling with in your conscious mind, when you get into alpha theta state, all of a sudden the solution pops in there. That's something that Thomas Edison discovered. Pondering some of his inventions, he would put himself into this state, hold like a steel ball bearing in his hand, and if he got too deep, he would drop it into a metal plate, and it would wake him up, and he learned how to get into that state and then get his inspirations. And emerging creativity, I had people that never had a creative bone in their body start writing poems, composing music, coming up with all kinds of great ideas, and they didn't know where that was coming from. But the most interesting was the transformative experiences. The changes in most people was kind of subtle and happened over time, but occasionally we'd have those really intense training moments, and that was totally transformational for them. Can liken it to a spiritual awakening. So I'm going to skip through this part. This is just some thoughts on the awakening process, and interestingly, the role that Jung played in his communications with Bill W. This is my favorite case study. This was a person who was a multiple treatment failure. He had no use for AA. He really had no use for group therapy or being in a treatment center or other people in general. He was widely regarded as a jerk, and he was like a thorn in our treatment population. So I went to him, I said, look, nothing has worked for you. Why don't you try this? It's all an internal process. You don't have to talk to anybody. You don't have to interact. You can let your defenses down. We're just going to do this inner work. He liked that, and he agreed to do it. So at that time, we were doing daily sessions. This is not a quick process in our treatment center. We would try to get in 30 sessions. So I got to the point where I was training people twice a day. We were doing it daily with him. He started getting some vivid imagery, and he would report afterwards that he started seeing this image of a wall, and then it was more of a circular wall, and it was around him, and he saw himself inside the wall, and people in his life were outside the wall. And it was kind of interesting. So we're talking about it, and he's gaining some more insight about what he had done, how he had walled himself off. And then at the 15th session, at that point I was getting him started. He'd internalized the induction process. I didn't have to do anything verbal. I just took him up, and then he was off and running. And I would get bored, I would leave the room, and I would come back in about halfway through, make sure everything's okay, and then leave the room again. When I came in to end this session, the first thing he said was, wow, and I said, wow, what? And he said, I wasn't alone today, and he said there was a presence, there was this entity, and he described it as kind of a dark, beady-eyed thing that at times it looked kind of small, and then at times it looked like the beast. And he said that I was fascinated with it, and I wasn't, I sensed fear, but I wasn't feeling the fear myself. And then when you walked into the room halfway through, it disappeared, like it was hiding from you, like you're the exorcist. And then when you walked out again, it reappeared. And he said it was just kind of part of me and around the room. And what do you think that is? And of course, therapists, I said, I don't know. What do you think it is? And we talked about it a little bit, and we agreed that we'd just go home and sleep on it. And he came back the next day, and he says, I know what that was. And I said, well, do tell. And he said it was a manifestation of my addiction. He says, I see that it's a part of me. I see that it can be kind of weak and afraid, or it can be big and overpowering if I feed it. He said, but the important thing is I don't have to fight it anymore. And I still get chills when I recall this, because that was his moment of surrender. I don't have to fight it anymore. And he said, I want to bring this thing back. I want to dialogue with it. I said, let's go for it. Didn't happen. We did 3 or 4 more sessions, nothing was happening, no imagery. And finally I said, I think you're done. And he said, I do too. And so we stopped there, and I followed him for 4 years. He never took another drink. He had a profound personality change. He was a mid-level manager at a large company. Went from being the jerk that nobody wanted to getting a promotion, and he had ruined his first relationship, but he was in a new relationship, and that was going well. And he became this really nice guy, and totally lost his desire to drink. So that was pretty exciting for me. Most of them weren't that intense, but that's what can happen with this. So those are just some of the things that I went through, and I already talked about those. One more case. This was a different kind of addiction, and this person was a therapist. They're always the hardest to work with. And I know when I was a patient, I was not a very good one, because I was always critiquing the therapist I was seeing. She was also a very large person with a very strong personality. The energy is always out there, and she's used to getting her way. And her addiction was to chocolate, and she wanted me to help her get off the chocolate. And so she, again, was trying to control the process and tell me how she wanted to do this. And I was standing firm. And so I said, well, the first thing we're going to do is the temperature training with your finger. And she objected, but she went along with that. And she struggled and struggled and struggled with that, because she was trying to bull her way through it. And the harder she tried, the lower her finger temperature would go. And finally, and I had her practicing at home, and finally one day she said, I just got so frustrated with it, I just said, I give up. And then she noticed that her hand was warming. And she reached the goal, which was 95 degrees, came back in, and then we went into the alpha theta. And the alpha theta was actually anticlimactic in that process. It was that surrender process that she went through. And we were successful with it. So I tend to ramble. So I'm going to try to get on task here. What we did at Anabasis is it worked so well. I got more equipment. I set up a training room with 6 stations. We would do 6 people at a time, and try to get them in twice a day. In a residential population, you can do this. That's the best setting for doing this kind of work. And we had some interesting field effects. If one person was just not with it, it affected everybody. If somebody had an intense experience, everybody seemed to. So there were some interesting field dynamics going on. And then running everybody through the Alpha Theta program and following them for 2 years, 70% of them were still not drinking after completing this. Knowing what I know now, I wouldn't have put everybody through the same process. And after leaving the treatment center, doing some of this on an outpatient basis, it was a lot more challenging. I had some successes, but a lot of things can happen between appointments. So I'm just going to go through this. Let's get that. A disadvantage is labor intensive. It's very costly, steep learning curve, and it's been difficult to get our controlled studies, because most of the work's being done by clinicians. So cocaine abusers, THC abusers, ADH individuals may already have excess frontal alpha. In fact, the frontal alpha is kind of they call it the California norm. It's associated with a lot of THC use, which is why it's really a bad idea for adolescents to be smoking, because their frontal lobes are still developing. The brain doesn't mature until the mid to late 20s, and you don't want to really anesthetize the frontal lobes. And if people have generalized too much alpha and you're training to produce more alpha, you're not gonna have as good of results. So that's when I realized it was important to really examine the organ I'm treating and to learn how to do the QEEGs and see what's going on in there. So if they already have too much alpha and theta, you don't want to increase that. And I think the 30% that didn't get well, that was a factor in some of those at least. So now it's I always want to do a QEEG. I always do a brain map and see what I'm working with. So we've kind of evolved into a comprehensive approach, which I put in place in my private practice, and what we've tried to create here at Mind Spa, and that's the Mind Spa part of our affiliation with Centerpoint. So I sum it up in terms of read, restore, reset, and rewire. So the read part is a good clinical interview and assessment, functional medicine assessment. We've got a functional medicine practitioner here now. My experience has been that when neurofeedback does not work, if you go back and look, we may be dealing with inflammation, toxicity, dehydration. They may have heavy metals, horrible diets, neurotransmitter imbalances. So we try to look at all of that, and the nutritional assessment is certainly a part of that. We have a nutritionist here with us. Acupuncture, I'm very fortunate to have one of the great acupuncture physicians around, in Rachel Tuman, who's got an equally rich and extensive addictions background, and that helps. It's another piece of information, looking at the whole system. So then, we go to the restore, detox, and acupuncture is great for detox. Rachel has all the protocols for that. We have a far infrared sauna here that helps with that process. Getting them on an anti-inflammatory diet can be helpful. Getting them to drink more water, taking a look at their nutrition, and doing proper supplementation to help correct some of those imbalances. I've always been a big believer in body work, and so we have a very talented cast of body workers here. We have 4 therapists that do the whole range of massage therapy. And something that I've always been one to think outside the box, something I brought to the first Mind Spa was the flotation tank, a sensory deprivation tank. We have 2 of them here now because it has been so successful for us. If you've never tried it, you should. If you have a client that needs help learning how to relax, send them over. It's zero gravity environment. You're immersed in this isolation chamber. You can do it sensory deprivation, where you're really minimizing any kind of sensory input, or you can have music, relaxing music, that sort of thing. But it has immense therapeutic value to it, as well as just something that's really enjoyable to do. So in the reset, what we're doing here now is we have a number of mechanisms. One is the Nexalin therapy, which I've had for about 3 years or so, and we find that it has a lot of utilization. It's a cranial electrical stimulation program involving one sensor on the forehead, one behind each ear, and it's a one-size-fits-all, but it targets the inner workings of the brain, the hypothalamic pituitary axis, and where it's stimulating a brain resetting process. So it's stressing the brain to sense what's out of whack and to start making adjustments. And they've done studies with this, and they show that it helps to regulate and normalize the serotonin, dopamine, beta endorphin, substance P for pain patients, and cortisol. And it's FDA cleared for anxiety, depression, insomnia, which covers everybody. And we've found that it's particularly good with addictions because it helps take away that craving, because it is hitting that reward center in the brain. And it's generally a 15 session, 40 minute per session protocol. And once we get them started, whoever's at the front desk can hook them up, and we just check in on them periodically. Again, there's no clinical decisions with that. It's just giving them the process. High performance neurofeedback, I abbreviate it as HPN. That's something that has become my go-to neurofeedback device. I started using it a couple years ago when I started participating in a nationwide study with retired NFL football players. And this is a device that monitors the dominant frequency moment to moment and feeds back a feedback signal, which is a little tiny electrical signal, presented at a offsetting frequency. Standard default is 10 hertz, so if the brain's giving us 3 hertz, we're feeding back 13. It gives us 7, we're feeding back 17. We got a lot of ways to do that in variable offsets, but it does a great job of resetting the brain. The brain can, if you look at the EEG, it can get into these phase lock patterns, and that's a stuck brain. And the brain needs to be able to freely go from one phase to another, constantly doing phase shifting and resetting. This stimulates it to do that. So we get it out of those phase lock patterns, and it can reorganize itself into a higher order of functioning. I believe that the brain retains a wellness memory, just like Dr. Huckabee was saying. We have an addiction memory, and it's easy to tap into that and activate it again. We have a wellness memory also, particularly after head injury, and it's always important for me, if I'm dealing with addictions, to take a look at head injury, because most people have had some sort of head injury, not as much as I've had, but a lot of times you have to really probe the history, and their first answer is no, but oh yeah, there was that one time when I was a kid when I got hit with a baseball bat, and yeah, that was a head injury. And that can affect what we're doing with the addictions also, so we always try to do that with the brain mapping. So a lot of times, all I need to do is do the reset part, and the brain figures it out, reorganizes itself, and we go on our way. The P. Roshi is another device that uses photic stimulation, as opposed to most AVS devices. Excuse me. That's entrainment. The P. Roshi is a disentrainment, so it presents a constantly varying feedback signal, which is like a false feedback of a fully functioning brain. And again, it'll do a good job of getting the brain to look at itself and to go into error detection and correction mode. ProSweep is another device we use. This is particularly good with PTSD. It's like an electronic EMDR. It has a sound that sweeps back and forth through your brain while you're focusing on the trauma or the feeling state, as well as the BAUD, the bioacoustic utilization device. There was just an article on this in last Sunday's paper that's being used with combat veterans to deal with PTSD. We've had that for several years now, and several of our practitioners use it. And again, when we're dealing with addictions, a lot of these people have head injuries, a lot of them have PTSD, and in addition and on top of the addiction. So the rewire is more the QEEG guided neurofeedback. Um, so I can do a lot of intuitive neurofeedback. If someone is depressed, I assume they have underactive left frontal lobe, overactive right frontal lobe. If they have OCD, you can expect overactivity in the cingulate gyrus in the center. And there are certain patterns that we can associate with symptoms, but there's no better thing than to actually mapping and seeing exactly what you've got, because a lot of times you get surprised. And the mapping is done with a electrode cap. It's a 19-channel EEG recording. We get gobs of information, and we offline, I go in and I analyze the data visually, have the computer give me a statistical analysis, run it against a age-matched reference normative database, and then I can also run it against a traumatic brain injury discriminant analysis. And applying some what's called Loretta, it's kind of a GPS coordinates type of inverse solution, you can approximate the subcortical source of a signal. So even though we're recording on the surface, a lot of this EEG is generated in deeper structures, and this gives us a nice tool for determining what's going on where. Brain Surfer is one of the latest technologies in terms of neurofeedback. I started doing single channel feedback and then 2-channel feedback. Played around with 4-channel feedback. With the Brain Surfer using electrocap, we can do 19 channels of feedback, so we can train multiple sites at the same time. We also use transcranial direct current stimulation, which is particularly good for depression. Audiovisual stimulation with CES. This is an alternating current cranial electrical stimulation. Cognitive behavioral therapy, always important. Of course, the addictions counseling. None of this, means much if they don't get the other stuff. And then EFT, clinical hypnosis. We have a talented practitioner, Darlene, back there, who does that. And of course, 12-step programs. I always tell people, whether or not you like the meetings or not, just get into the steps, because they're very sound. Okay, so I've been talking about brain maps. Here's an example. So this one, on the top row, left to right, we're looking at standard frequency bands: delta, alpha, delta, theta, alpha, beta, and high beta. So left to right, low arousal to high arousal. The green indicates normal based on the reference database, and the yellow, orange, and red is above normal, and the blue is below normal. The top row is the absolute distribution of power, and you can see that in the high beta range, we have a lot of excess activity going there. And this is an over-aroused brain. If you look at the center, you see the alpha is blue. That's low alpha, so that's an alpha deficiency. So this is the kind of brain that would really like alcohol, because it would lower that high beta and would elevate the alpha temporarily. Of course, when the alcohol wears off, then we go back to brain irritability and more high beta. So you have to have another drink, which was the basis of why we were doing the alpha training in the first place. The second row there is relative power. All of those heads added together add up to 100% of the distribution. You can more clearly see the alpha and the beta, high beta imbalance. And then we can also look at amplitude asymmetries, connectivity measures of coherence and phase. So this brain is working pretty well, except for that major imbalance up there. So it's important to look at all of those factors. So with Brain Surfer, we can bring up a menu like this, which enables us to really customize the protocol that we want to use. We can, we always try to match findings to symptoms. I see a lot of abnormalities in the brain. If I can't match it to any kind of a problem or symptom, I leave it alone. So I don't want to take away any attributes from people. Particularly when you have high-functioning people, by definition, are not normal. We don't want to regress them to the mean. We want to zero in on the abnormalities that are related to problems, and then we can train those. And with Brain Surfer, we can train several points in the brain at the same time, and we can train connectivity between them. We can identify the Brodmann areas we want to train, or we can train networks. There is a depression network, there is an addiction network, there's an executive network, there's a default network, salience network. We can train all of those. So there's the standard Brodmann areas that I haven't memorized. I use a reference for that. And then here's the Brain Surfer feedback display. This is a depiction of the addiction network. And you can see there are a lot of nodes involved in the network, and then the lines represent connectivity between the nodes. And just about everything that happens in the brain happens in terms of a network. So it's important to train the whole thing. And the way this works is it lights up red if you're way off the mark, yellow if you're close, and green if you're meeting the criteria. And then there's sound associated with it. So the subject can just focus on the screen and try to keep everything green and keep the music going.
George?
Yes?
I have a quick question. So in that network, would those addiction networks show up the same for your client who had a chocolate addiction or say a sugar addiction versus somebody with an alcohol addiction? It's the
same network. It's that reward system. And we train what the mapping is showing is deviant, is a problem area. Because the problem can be in one node or it can be in any particular area. I know we're out of time here, but just one amusing or interesting anecdote. I read this week about someone who cured himself of OCD, extreme OCD, by attempting to kill himself. He took a gun and put it in his mouth and shot straight through, and just by luck happened to wipe out the node that was really fueling the OCD. He survived it, he recovered, and his symptoms were gone. And he retained his... I would not recommend that to anybody. Because, gun in the mouth, bullet, what could possibly go wrong? So just to wrap up here, brains can get stuck in a suboptimal or dysfunctional pattern. And we see this all the time when people are not responding to therapy, their brain is stuck. I've had people that have come in and take a look at their brain, get their brain out of those stuck patterns, and then all that psychotherapy they've been doing for years, starts to work for them. So it couldn't before because the brain was stuck. Nature of the brain is to resist change, unless you approach it in the right way. If you approach it with a hammer, it's going to resist strongly. But if you go in there and subtly tweak it, it'll accept those changes. And they're very capable of self-correcting. We know now that there's such a thing as brain plasticity throughout the lifespan, and the brain is capable of sprouting and pruning and rewiring. And a fit brain displays flexibility, resilience, speed, quickness, agility, balance, strength, endurance, and calmness. So I started equating it to physical fitness, and what we're really doing is getting the brain more fit, and then everything works better. So So all of these wonderful things happen with neurofeedback. And then just to close here, temporary solution is the beer. Here's the permanent solution, a meeting with yourself. And it's for everyone. These are the Roshi glasses. I talked about the Roshi, and people have cured their pets, they've taken home their Roshi machine and putting these glasses on them. And the pets like it, and they find that they go and lay down by it, I want another treatment. So that concludes it. Thank you very much for your attention. I know we're out of time, but